So dosimetry, yeah, that's an interesting topic. You know, we work from time to time with radiation oncologists, and when we start to talk about dosimetry, it seems that dosimetry doesn't have exactly the same meaning for us and for them. So I thought it was interesting maybe to go back to the definition of dosimetry, and at least for the radiation oncologist, the determination of the amount of dosage or radiation absorbed by a substance or living organism is dosimetry. Okay. So, question: what is PDT dosimetry? What does that mean? So, before answering this question, maybe I should say maybe dosimetry is different from monitoring, and I think very often there is quite confusion between the two things. Monitoring is a supervising activities in progress to ensure that they are on course or on schedule in meeting the objective and performance targets. So, monitoring. If you want to know the photosensitizer concentration in situ, in order to adjust the dose, maybe to adapt maybe the amount of light, that's not dosimetry, that's monitoring. And that could be very useful to know the drug concentration. I can give two examples, for example, in dermatology, for BCC or actinic keratosis lesion. We know that if they do not respond well, it's usually due to the amount of PP9 inside. Okay, you apply the same layer of Medvix, of methyl ester, ALA, but at the end you don't get exactly the same amount of PP9. So you need to adjust maybe things as the amount of concentration. And you have some way, for example, in that case, you can use fluorescence. I know, for example, and I like that very much, in Brazil, before starting the treatment, they perform the measurement. We have also the example, another example in gastroenterology. It's a very interesting study performed by Georges Vanière and his group, where in fact they demonstrated that despite the same dose, that means the same intravenous injection of MTHPC in that case, the MTHPC plasma level was different for each patient. And the PDT effect was correlated to MTHPC plasma levels. Again, that's not dosimetry, that's monitoring. So, and they demonstrated in, that's another study performed by the group in Munich, that in the three patients with a strong PP9 fluorescence, they obtained very good response. But in the other two patients, where they showed and observed very low PP9 uptake, early treatment failure was seen in this patient. Another parameter we can measure is oxygen. And the amount of oxygen plays also a role on the photochemical reaction. So I don't want to spend, some of you are really expert in that, but we know that the amount of oxygen is play a major role about the PDT effect. And for example, Alison Kurnau, I think she's in the room, and has clearly demonstrated that that's a problem with this projector, but when you start to illuminate the skin, your lesion, you have oxygen consumption, so you stop, in fact, the photochemical reaction. So, that was about monitoring. Dosimetry is not monitoring. Monitoring is not dosimetry. Dosimetry is not metrology, and metrology is not dosimetry. And metrology, that's the science of measurement, embracing both experimental and theoretical determination at any level of uncertainty in any field of science and technology. I'm going to take two cases. We were, in fact, really concerned by these two applications. One is in dermatology for the treatment of actinic keratosis again, and the other one is, in fact, the treatment of prostate cancer, because we were deeply involved in the development of treatment planning software and so on with Steba Biotech. Let's start by, in fact, this LED panel. When you buy the LED panel, you are even not sure that the light distribution is homogeneous. That's the case. I mean, I mentioned that 2 days ago. That's a study performed by Harry Mosley in Dundee. He clearly demonstrated that on a flat surface, in fact, due to the fact that each LED was different and was not calibrated inside by the company, you don't get the right amount of light. So for sure, you have some trouble. Due to the complexity of your human anatomy, even if you determine a dose, and I will come back to that, to what is real dosimetry. If you are not able to apply this light, this amount of light, you are in trouble. No need to perform dosimetry. You just, so in that case, if I have a curvy surface, it will be difficult to reproduce the irradiance. So it will be difficult to obtain the expected dose. So we had several clinical evaluation in progress in Lille, and that's a study performed by one of our residents, Claire. I think she was there the last 2 days. When we did something, we're going to publish that because, I mean, it's so simple, but I never see this published. So, we asked an expert dermatologist, an expert in PDT, to apply, these LED panels on the head. And what we did, we took a power meter. Here, you see it's a very small surface, 1 centimeter square, and we measure in different locations on the head the irradiance. So the good one should be that one, you see? And if you move from the red to the blue, that means you decrease from the optimal one should be between, let's say, 90 to 100% to almost nothing. So you can see here at the center, yeah, it's not too bad. Maybe I get 70, 80. But when I start to move to the borders, it decreases. So if my optimal dose, optimal light illumination was supposed to be 37 joules per square centimeter, I can tell you here, it's, I can get only maybe 1/10 of that. So, I can say I determine the dose, I perform a lot of mathematical modeling, I did a lot of study on animals, but if I'm not able to reproduce and to apply the amount of light I'm supposed to apply, I'm in trouble. Let's move to prostate. When we were contacted few years ago, 5, 6 years ago by Steba Biotech, they were already running some clinical evaluation, and they came to us and they say, we determine the dose with experts, but we have some trouble delivering the dose, and something's wrong. Could you check that? And so the technique, as you know, you insert, in fact, a catheter, you insert the fiber, that's a diffusing fiber, and you should get this kind of illumination. In fact, it was like that. So we perform in our lab what we call optical gonometry, and in fact, at that time, there were 2 providers of fibers from Steba Biotech. I will not mention the name. But one was able to deliver exactly what it was able to. But the other one, it was not the case. And I can tell you with your naked eyes, it's not possible. You need a very sophisticated system. You need to know metrology, which is a science, to determine this thing, and then be applied. Because, the position here of the fiber was good, but in fact, I was not illuminating what I was supposed to illuminate. And about the fiber positioning, that's other thing. That's another paper by a group of Steve, where they demonstrated that, in fact, the amount of light was really correlated to the light delivered to the tumor. So first conclusion of my talk. Monitoring and metrology should be major concerns. Fluorescence monitoring could be useful. Oxygen monitoring could ensure more complete insight. Reproducible and accurate light source positioning is crucial. And light dose homogeneity, etc., should be controlled. So now let's move to dosimetry. So again, dosimetry, the determination of the amount or dosage of radiation absorbed by a substance of a living organism. And I think we should really follow and use what is used already by the radiation oncologist. If you want to promote PDT, we should use the same word, we should use the same approach. Otherwise, we are in trouble. So, and the radiation oncologist, when they want to determine the dose, when they want to know what they are doing, they use the dose volume histogram. So the choice of any radiotherapy treatment plan is usually made after the evaluation of a few preliminary isodose distribution obtained from different beam configuration. In our case, it will be from different light configuration or fiber configuration. So for any dosimetric plan considered, data on dose volume histograms supplied by treatment planning system are used to provide estimates on planning target coverage as well as on sparing of organs at risk and the remaining healthy tissue. So that's already, okay, we have this ratio between the amount of drug inside the tumor and the surrounding tissue, but we should do, based on that, we should be able, and we are able to perform dose volume histogram. So that's an example in radiotherapy with 50 gigagray of radiation, where, okay, that's the case of the prostate. So most of the dose is inside the prostate, and for the surrounding tissue, what you want is, in fact, to have a minimum dose in order to protect that. So what's it, in fact, so again, just for you, maybe for people that are not really familiar with dose volume histogram, it's a graphical representation of a dose that is received by normal tissue and target volume within, and in our case, I can take now the example of photodynamic therapy, of 3D photodynamic therapy plan. This DVH provides information on volume of a structure receiving a given dose of a range of doses, and operating within this defined planning volume, the dose volume histogram displays the percentage of each organ within the planning volume receiving this dose. So to date, most of, and in the context of photodynamic therapy, most of these DVH, dose volume histogram, are based on simulation of fluence field. And accurate dosimetry and treatment planning require knowledge of tissue optical properties and models of light propagation. We have that already. But now we are to use and to provide information, I would say, in the context and the same approach of a medical oncologist. And okay, doing that, we can perform this simulation, and there is that very important field representation, which is the D90, which is the minimum dose received by at least 90% of the tumor. So now there are a good group here in the community, in the PDT community. There is the group of Lothar, which has done very interesting work, and I think his student, his partner, yeah, Cassidy is here. So that, and is in the audience, so if you need some specific answer, you have the author of that paper, okay? So unfortunately, again, with a projector, but you can see here that the dose inside the tumor and the normal tissue didn't receive any harmful dose, and you can really protect by proper selection of light and the proper positioning of the fiber. You can treat the tumor and protecting the surrounding tissue. And if I show that to a radiation oncologist, he will understand. Other example, again, it's a pity because it's really nice with a curve. Another group, via this Thomas Foster, and I think I took that in the PhD thesis of Baran, where in the same they display, in fact, this DVH, and you can clearly see that you have high dose in the tumor and almost no dose, which was DVH 90 in the tumor. we start even to have companies, and SpectraCure in Sweden, they develop a system called iDose, so that's the concept. And Anne Johansson, in that group, when she was working in that group in 2007, has also very nicely illustrated this dose volume histogram, and as you can see here, the distribution inside the tumor and inside the normal tissue. That's a dose volume histogram, that's dosimetry. The two last examples, in fact, development performed in my lab in Lille. So that was the approach for, in fact, the treatment of prostate, and that this approach is integrated in the software called two-guide MRI, which is part of the treatment planning software from Steba Biotech. And more recently, with Maximilien and Clément and the team, approach also to perform the dosimetry and to really determine the dose volume histogram and the dose inside the tissue that we call IPDT plan for the glioblastoma. So, conclusion, I was fast, in fact, but I have important announcement. And I don't remember some of them, but and I know I am in trouble. So a useful dosimetry should lead to DVH representation. I think that should be, as a community and PDT community, and we should make progress all together. Okay, and now if you want to, what we need is really to promote that technique and to convince other people that PDT could play a role. But we need, now we are competing with radiotherapy, with chemotherapy, and we need to speak the same language sometimes. To date, in the context of photodynamic therapy, most DVH are based on light fluence dose, but I think we could do maybe and improve that, but it's already a good approach. And maybe, again, that should integrate in the final software not only the light fluence dose, but the oxygenation, the photosensitizer concentration, and the tissue sensitivity. So that's it. So I've, like, you know, as you know, this work is performed with many people in my lab, but I can mention Clément with his PhD student, Wael, Gregory, Anne-Sophie, and Maximilien, which we are working together now for several years. So several announcements. The Brixton meeting. So the Brixton meeting this year was in Nancy. The next Brixton meeting will be in Germany, near the Alps, 1 hour from Munich. It will be a few days before the Oktoberfest. And so we will have plenty of time, you know, to wear this strange hat and so on. And Ronald and Herbert, at the end of the session, will give you some nice postcards. You will get all information about this meeting. It will be in 2018. It's every other year. And in September, it's supposed to be, you know, they sold the place very nicely. We're supposed to have sun, nice food, and good beer, and everything. You confirm? Yeah. It was mentioned by Tayaba a few minutes ago. So next year, we will have the IPA meeting, International Photodynamic Association meeting. It's also every other year. Last year it was in Brazil, in Rio de Janeiro. It was beautifully organized, and the place was really nice. It seems now to organize a PDT meeting, or at least for IPA, you need to speak Portuguese, because it was in Brazil and it will be in Portugal next year, in Coimbra. Coimbra, it's a very nice city. You know, I know a little bit Portugal, and Portugal you have several cities. On the north you have Braga. And Braga, they say, that's the city where people pray. You have Porto, they say, that's the city where people work. You have Coimbra, that's the city of people study, and you have Lisbon, the city where people dance. Yeah. That's true? No Portuguese? Yeah, that's true? You confirm? Yeah, thank you. So now, some announcement. You got in your bag this survey and so on. I spent a few years, to prepare that. So please fill it, because we need your feedback to improve the meeting. What else I must say? Oui, c'est ça, oui. Yeah, you have a specific box. Yes. Yeah, and you put inside the box and you win something? Yeah, you have a number and one of you can win something. Tonight. C'est quoi? We still don't know. But you have a chance to win something. Something else? Yeah, alors, you will see, tonight we have a very nice gala dinner. You will have some kind of surprise. I can tell you more, but at the same time there was another big meeting in Nancy. Originally we thought to mix the two meetings together, but it did not happen. But at least some members of that meeting, which is international meeting? National meeting, will come to our meeting, and you will see that's a different specialty. But I encourage you to come. And there is a gold, you say gold book? Livre d'or? Yeah, gold book. So a gold book will circulate tonight, and we'll have the opportunity to write a few words. And I give mic to Céline, because she's the big, that's the boss. Not the big.
And I asked the invited speaker to give me back at the end of the session all the grid of evaluation of the poster and the oral communication, because after I will have to analyze, and tonight we will give the prize of the best poster and the best communication. So we are very sorry for the people who are talking tomorrow morning, because of course they cannot play, but we promise if we organize again this conference, these people will talk in the beginning of the session next time.
So we do have time for a few questions on science for Sergei, but are there any questions? Yeah, please. Sorry.
Hi, this was a very nice presentation. And you mentioned in your conclusions that we have to take into account also other factors, not only light. So basically we should dosimetry the killing factor, like they do in radiotherapy, right? So do you have any ideas about that?
No.
Because this is not light.
No, I have some ideas, but okay, we are working on it. I think other teams are working on it, and okay, that's yeah. But specifically, I cannot answer to your question. I'm sorry about that.
Next question. Yeah. Go ahead. There's one there.
Yeah, I got one question. Do you also work on dynamic planning? Because as soon as you switch on the light for PDT, your absorption coefficients will definitely change, and your scattering will change slightly as well. And I can assure you, it can go in all directions. So you make a plan prior to your treatment, but as soon as you switch on your laser, you get a big problem. Is that something that you work on?
You know, that's interesting, because it was a huge debate in our group and with companies. You know, I'm in that field for 36 years. Okay, I mostly work with thermal laser. With thermal laser, I agree 100% with what you said. But I would respectfully disagree on PDT. Because as soon as you inject the photosensitizer, the main chromophore is the photosensitizer. So I don't see any reason why you will obtain some, in real time, you know, under the laser flux, a modification of your optical properties. Except if you perform temperature increase at the same time. And it was exactly what happened when Steba Biotech came to us with the idea to, because the prostate, even with it's highly variable. Right? Even from one patient to another patient, if you consider the absorption coefficient, the scattering coefficient, if you mix the two in the extinction coefficient, you can have almost a factor 4. But again, we don't treat the prostate alone. We treat the prostate with a photosensitizer, and the light we use for the photosensitizer is in the peak of the absorption of the photosensitizer. You know, usually to explain that, I say we have in, you know, France, we are very good for the wine. You know, you have a wine tester. But, you know, we have also people who are able to test the water. And they say we have water for the center of France, the south. I'm always surprised they test and say, yeah, that's different. But you put a drop, just a drop of orange juice at the end. The test is the test of the orange juice. So that means even if you have variation of your optical characteristic, if you inject the chromophore and if you have your photosensitizer, maybe you have slight variation, but I don't think it will play a major role. But we can, at least I can tell you it works for on prostate. No, you need a mic, otherwise I will not answer.
Okay, yes. So I see we think along the same lines for a lot of the dosimetry, and thank you for mentioning our work in Lothar's group. One big difference I see from radiotherapy is in radiotherapy we are imaging with X-rays and treating with X-rays, and so we have pretty good certainty over the transmission properties, and we don't have that in optical means. And I'm just wondering, I don't really have a good answer for this, but how do we, or how could we take account of that when we present the plan? So the dose volume histogram is a line, but there's some significant uncertainty in that, I think. And I'm wondering what your thoughts are.
I agree. I think we still need to work on that. But we need now, as a PDT community, to say, okay, if we talk about dosimetry, we should start, you know, to make the confusion between monitoring and dosimetry, metrology and dosimetry. I think we need maybe to define our own dosimetry, but should be very close and should be understandable by a radiation oncologist or other specialty.
Thank you.
Yeah, I agree with that.
Okay, so before we close, I think we're finishing 5 minutes earlier, so please come back at, oh, you do have a mic.
Yeah, two quick comments.
So we're not finishing earlier.
Sorry, the first, with regards to changing optical properties, when we looked at the prostate, when we were measuring the light fluence and the optical property changes, sensitizer could change a bit during PDT, but the optical properties didn't seem to change too much. In the chest, we've not done quite as good a job as measuring it, but I can tell you just looking at it. So we go to 60 joules. By 20 joules, and as I think you guys have seen now too, the intralipid that you're pouring into the chest is no longer bloody because you've now cauterized the oozing of the blood in the small capillaries over the entire surface of the chest. And clearly when you finish at 60 joules and you look, you can tell the tissue is treated. It has this whitish sheen to it, which by the way was present with photofrin, but not HPPH at the doses we were getting to. So I think there's interesting.
I agree. When, you know, for this kind of talk, you have to simplify, in fact, the talk, and maybe when you go in details, we will have to study photosensitizer by photosensitizer for each, application. What is the real situation? But the main idea of my talk was really, okay, we should use the same word, have the same approach, and now maybe all the different teams, and we have already several teams working on that. We should go in that direction.
As the resident, I guess, and perhaps only radiotherapist in the room, we began using radiotherapy based on Curie burning his skin and Becquerel doing his first time dose fractionation study with the radium vial in his pocket. We had no idea what dosimetry meant. It's been 120 very long, hard years to try to even understand it, and we're still coming on this. I just had to do 4 treatment plans again this week as they did an interim scan and the tumor had changed and we've got to redefine. So, you know, we still struggle in radiotherapy with a pretty obvious thing of just tissue ionization and absorbed dose, how to define this. And I think we can't allow perfection to be the enemy of pragmatism in PDT.
Yeah, with radiation, it's a much bigger problem if you go off. So that's PDT is much kinder and gentler. So.
Yeah.
So I think with that, we're going to end. But before I end, the Munich people are here, the next Brixton guys.
Yeah.
How do you get to this place? Do we have directions for that?
It's by train, 1 hour by train from Munich.
Yeah, right.
Yeah.
Okay.
And there is one, I was told, Köchel? What?
Yeah. 1 hour. And you'll have directions so people don't go to the wrong place. Yeah. Okay. Yeah.
There is only one city called like that in Germany.
Not 2 Brixtons.
No
okay.
to Brixton.
Okay, good. All right, so I think we did finish, still managed to finish a few minutes earlier. So please be back by 4:45 so we can leave early. Yeah.